our speaker for the keynote, Dr. SIDDIQUI PARVEZ Ahmed, to present his presentation on Gunderson flap as a low-cost solution to a lot of corneal problems. Dr. SIDDIQUI, please.
Thank you, honorable dignitaries on the dais, and I request and convey my regards to the AIOC for giving me an opportunity to speak upon a thing which is of very rare entity. A Gunderson flap was started by Gunderson way back 5 to 6 decades ago. His name has been misinterpreted by most of us. There is a S-E-N, actually. His name has been misspelled in a lot of literature. His should be actually spelled as S-C-N. Why we require a Gunderson flap in an era where technological advancement has taken to an extent where everything is available, but places, far-flung places like Jabalpur or any other places which do not have access to each and everything, and for acquiring these amniotic membrane, bandage contact lenses, and rather the most sophisticated part, the cornea. In COVID era, we found a drastically decrease in the amount of patients or donors who were willingly trying to donate. And unfortunately, the disease were also not being, we could not retrieve cornea in these patients. So we thought, why not in certain circumstances in which the patient is requiring an urgent corneal surgery to achieve a stable ocular surface? Because it does two things. The Gunderson conjunctival vascularized flap does two things. It assures us a very stable ocular surface, and side by side, it also represses the inflammation. The inflammatory component is also suppressed or repressed. We are using this Gunderson flap, or rather I recommend the use of Gunderson flap in those patients who have slightly reduced visual potential. But in studies conducted by various authors and from LBPI and from Dr. Fogla has got a few literature which has clearly demonstrated that if you do not scrape away the limbal stem cell, rather, and we can scrape away the rest of the cells, you do have a very good visual potential after removing the Gunderson flap in the later on scenarios. So we found out in our literature or in our work, it still holds some ground in COVID era. Still the COVID is going on. Still we have got certain cases. Those are newer modalities we have already discussed: therapeutic penetrating keratoplasty, amniotic membrane transplantation, therapeutic bandage cord lens, and other modalities which we are using it for these various types of corneal surgeries which require corneal transplantation or a perforation, has high cost to bear. And there is also a delay in availability of these things. So they constitute a considerable technological progress, but they have got some impediment. I have already discussed these. Limited availability is one of them. So we are using a Gunderson flap for the following purpose: to recover the integrity of the corneal surface as soon as possible, to prevent gradual corneal ulceration from progressing and from seeing that the secondary infection do not take place in due course of time, and to achieve several other secondary effects of the conjunctiva as such is a very potent source for the mucin layer and for other various anti-proteolytic activities also. So they have been advantages are many, ranging from relieving pain, reducing topical medications, enhancing the aesthetic appearance, providing an option to invasive surgery or enucleation. In private setup, nobody is willing to go for enucleation or a destructive procedure to any extent. We have seen various reasons for that. So what happens when you use this Gunderson flap? It covers the affected corneal tissue and prevents tears, proteolytic enzymes, pro-inflammatory mediators from reaching the corneal ulcer and causing stromolysis. And it supplies the compromised corneal tissue which is already compromised due to ulcer, due to infective process, due to various inflammatory process, with a vascularized tissue that prevents further damage. Means it is not the damaged tissue is not exposed to the external environment to any extent. The rich supply of blood, it is a highly vascular tissue, and lymphatic vessels provide nutrients, including cellular components and growth factors. So somewhat of healing process is also augmented with the use of Gunderson flap. And since it is having an external covering, the cornea is having an external covering, so you have got some sort of a resistance to infection also in these cases. These are the various advantages. And one of the most important one, the enumerated fifth in the line, is anticholinergic substance that suppress stromal ulceration. When you do the peritomy, we are using a peritomy in various procedures like Moran ulcer and various causes, various diseases in which peritomy is required. Peritomy, though it causes some sort of removal of the cornea from the limbus, and it decreases the various types of supply and nutrients to the limbal stem cell, but it also decreases the circulating antibodies to the areas of ulceration. The cytokines, circulating antibodies, and other pro-inflammatory factors are reduced at the area of ulceration. That is also very important. I'll be discussing bullous keratopathy. And when you cover the cornea in a case where scleral shell prosthesis is desirable, there you can use this Gunderson flap because it reduces the corneal sensitivity. This is a basically complete Gunderson flap surgery which has been done. You can see the vascularization over the surface of the cornea. Indication are far and wide, but we will be discussing the limited indication, that is herpetic keratitis, and that too acute stromal necrotizing keratitis. We are not discussing the epithelial part, we are discussing the stromal part. In stromal part, where the avenues for treatment are far and wide, very less. Where in a matter of time, you find that the cornea has melted away in acute stromal necrotizing keratitis. In bullous keratopathy, if the patient is very, very in pain and you don't have access to the corneal tissue, so you can use this particular remedy or modality in bullous keratopathy. Neuroparalytic keratopathy is one such condition where the patient will not tell you anything. He just keeps on getting his cornea melted away, he keeps on getting his cornea inflamed because the corneal sensation are reduced or on account of HSK or on trigeminal neuralgia treatment or various schwannomas and various central corneal disorders where the rate of mitosis has gone down dramatically as compared to the normal mitosis. And in traumatic relapsing keratopathy, in which you find that the keratopathy is increasing day by day, and it is relapsing once you have got remission and exacerbation phase. Role in herpetic keratitis is it's just limited. Those stromal keratitis which is unresponsive to topical and systemic antiviral. No topical acycloguanosine or ganciclovir, any sort of newer modality are not at all being effective, or they are not able to control the remedy, the malady, and systemic antiviral. How long you can give? How long you can give acycloguanosine? How long you can keep on giving them? And the patient is having this particular acute stromal necrotizing keratitis. This Gunderson flap is a very effective remedy. It replaces the diseased stroma, but with healthy basal tissue on which stable epithelium can evolve. At least we are giving an opportunity to the patient of acute stromal necrotic keratitis with this particular treatment modality. There is stabilization of the ocular surface. In some trend literature, I do not want to quote the author, but it has been reported in literature, the ocular surface epithelialization they were able to obtain approximately 3 days after institution and implementation of this Gunderson flap. In bullous keratopathy, you know, the exposed corneal nerve is always something which patient tells you. He always complains of pain, lacrimation. So this particular malady forms a sort of a covering, and it also forms a partial osmotic barrier at the tear epithelium interface. So this alleviation of the pain, restoration, secondary infection becomes one of the important factor as far as role in bullous keratopathy is concerned. Neuroparalytic keratitis I have already discussed a lot. It has affected, it is brought into the neuroparalytic keratitis. You have got neutrophils, a pro-inflammatory mediator causing destruction of the tissue to such an extent, along with the cholinergics, you lose your eye. The patient loses his eye very dramatically in within a few days. So by placing a Gunderson flap, patient can preserve their eyes and maintain an adequate cosmetic appearance, a goal that can be improved by using conjunctival flap as thin as possible. You take a very thin flap. I'll show you later on. List of infection, the list of indication has improved in due course of time: chronic infectious keratitis, tectonic indication, corneal ulcer, refractive. One thing certain about the contraindication, people say, okay, use the Gunderson flap. But is it possible to use Gunderson flap in all and every case? Some patients say, and some authors have also advocated not to use Gunderson flap in autoimmune disorders like Morin ulcer. They have contraindicated, or rather they have discussed and they have their own areas of fears regarding use of Gunderson flap in these circumstances. So these are the types of Gunderson flap which we are using: total conjunctival flap, a bipedicle bridge flap, a single pedicle flap, advancement flap, a superior FORNICEAL conjunctival advancement flap. This is a diagram of a total conjunctival flap. Only thing is that you cannot measure the intraocular pressure. You cannot have an access to the increase in intraocular pressure assessment. Sometimes if you bring the whole of the conjunctiva over the cornea, sometimes you have a shortening of the fornices also, which I have seen in few cases. And levator aponeurotic attachment sometimes also get loosened out in these cases, resulting in ptosis. Pacifications are there. And for the least, conjunctivalization of the cornea is also present in these cases. So we have fears regarding the use. So we use it for specific purpose and for specific indication, and minimize the use of conjunctival flap to a bare possible level as possible. So one of the modality is bipedicle bridge flap. It is used for small central or central corneal lesion. So it does not cover the whole of the cornea. Then a single pedicle flap, very good, very good. It is a racket-shaped flap which covers the perilimbal corneal lesion, but only thing is that it sometimes retracts. This is a representation of a single pedicle flap, but sometimes it retracts. That is a disadvantage. Advancement flap, everybody has done in their clinical career. You just advance these lesions in the perilimbal lesion area. And this is the superior FORNICEAL conjunctival advancement pedicle. Only difference is that we are using the graph from the fornices, so that the conjunctiva can be utilized for further glaucoma surgery. Or you find that in areas of peripheral corneal vascularization, the conjunctiva is very, very friable. So you have to go for this particular modality of treatment. Complication, you are all aware, nothing much is there, but visualization of the intraocular structure is foremost. You cannot visualize the intraocular structure. That is, and when you use a very thick flap, you are not very kind enough to remove the tenon capsule, then the cosmetic results are not very good. Complication, they are all enumerated. They are all enumerated. So I'll go for...
Dr. Siddiqui, can you please summarize?
Yes, sir. I'm just concluding it, sir. Conjunctival flap surgery is a very simple, effective, and cost-effective method of treatment for ocular surface disease. Resistance to medical therapy. The goal of this surgery is to re-establish the integrity of the corneal surface as well as to relieve pain. It can reduce the need for further medication. It enhances the aesthetic appearance, provide an alternative to invasive surgery, and it can also be used as a temporary measure when the corneal graft or the corneal button or the corneal tissue is not available for good cases of penetrating keratoplasty.
Thank you, Dr. Siddiqui.